tea, and I would like to go into research or do something. So I wanted to do MD Pharma. So I was back to Gautam Nagar after internship, preparing for the PG exam. And I prepared for 1 year and I got a good rank. My aim was to get a PG seat in pharma in Delhi. And I got MD pharmacology seat in UCMS, Delhi. And I did my MD in pharma and I wanted to go into research, but it so happened that once I started teaching the undergraduate students in UCMS, I kind of got a knack for it, or I used to get my kick from teaching. So gradually I diversified into the field of teaching and all. So guys, I usually don't like much to talk about myself because I consider me to be the past. I've lived my life and I have done whatever I wanted to with my life. I like to talk more about you guys because you guys are the future. But anyways, here today I'm talking a little bit about myself so that it gives you some kind of motivation that you can do anything in your life. I mean, the first thing I would like to tell you is you do not underestimate yourself. If you are an FMG, it does not mean you are less capable than an IMG, Indian medical graduate. You are as good as an IMG. You are equally capable of doing things what the IMGs do. There are a lot of FMGs nowadays. Forget about PG. They are also in central institutes like AIMS, PGI, JIPMA. Yes, there are a lot of FMGs, guys. They're able to make it, right? So that taboo is gone. The differentiation is not there. It is getting thinner day by day. So you can do anything in life, but the beginning or the very first ingredient that you need is self-belief, faith in yourself that yes, you can do it. And with adequate guidance, guys, strategy and planning, you can always make it in your life. Now remember, see, being an FMG, when you prepare for the FMG exam, you are actually 60 to 70% prepared for the NEET PG exam. You just need to do that 30 to 40% extra effort by solving Q bank and watching selectively few subjects videos. You can go and rake in a good rank in the NEET PG. So it's not altogether a different approach. It is just the same subjects is going to help you. So it's my suggestion, whenever you are done with the FMG exam, keep your notes. They'll help you for the PG exam. Now, in today's session, guys, I'll talk briefly about a topic which is called as anti-arrhythmic drugs. And anti-arrhythmic drugs, it is the most arrhythmogenic topic for the students, right? So I'll talk about what is arrhythmia, how arrhythmia is treated, and we'll talk about concepts and how physiology is integrated into pharma, how pathology is integrated into pharma, and how pharma is then integrated into medicine. So integration is the key today in India. The curriculum has changed. So when I integrate pharma to physiology or pathology, this is called as vertical integration, right? And if I integrate it to some other subject like medicine, etc., it is called as horizontal integration. So we'll integrate that. We will see. At last, many of you might be appearing for the next exam. So I'll end today's session with some guidance about next. What is next? What you can expect from next? How next might change your fortunes in a positive or a negative way. And apart from that, we'll also talk about your doubts. Whatever doubts you have, you can shoot at me in the end of this session, and I'll be more than happy to clear all your doubts, because whichever exam might be in medical, be it the MCI screening, the PG exam, I have been through the nooks and corners. And believe me, those students who are going for the exam, the June exam, I can understand what goes through the mind when you are going for the FMG screening exam. A lot of things, they keep on running through your mind. The first thing being, what if not this time? I will be into this juggernaut, into this torture for another 6 months. That's the first thing. Second thing, what will I say to my parents? Then third thing, what my parents will say to my relatives, isn't it? So all these things, I have been through that. I know that. So guys, whenever you try to little bit loosen up in your preparation, remind yourself, would you like to repeat the same thing again for 6 months? No, right? So buckle up and go for it. So guys, today, as I have said, I will talk about one important topic in CVS, that is anti-arrhythmic drugs. And at last, I'll solve 10 questions with you guys as well. And I'll try to make you understand why the era of mugging up is gone. The era of mugging up or rote learning is gone. You need to understand if something is happening, why it is happening, right? So the reason, there is a reason behind everything in medical science. You need to find that reason. So guys, anti-arrhythmic drugs. See, anti-arrhythmic drugs, these are drug used for treatment of arrhythmia. And before you can even think about what drugs are used for treatment of arrhythmia, you must know what is arrhythmia. And if I want to know what is arrhythmia, I must know what is the normal rhythm in the heart. Now, if the rhythm is disturbed, if the rhythm goes for a toss, if the rhythm is disturbed, I'll call it as arrhythmia. So what is a normal rhythm? So this is now we are trying to integrate physiology with pharmacology, right? And you see, guys, everything has some benefit. I mean, it's uh, not just integration for the namesake. It is integration for understanding. And at last, it will help you at the level of patient. So what I'm going to tell you today will not only help you to solve MCQs, but also will help you to treat patients when you become actually a doctor in the clinical field. So normal rhythm of the heart. Suppose if this is the heart, then you remember there are two types of tissues in the heart. One, these are nodes like SA node and the AV node. These are nodes like SA node, AV node. Then we have the conduction system. And then we have this myocardial cell. So this is your myocardial cell, SA node, AV node. Now, there is some difference in SA node, AV node as compared to the myocardial cell. The reason being, what is the role of SA node? What is the role of SA node? See, SA node, it is known for spontaneously generate action potential. It spontaneously generates action potential, and that is around 60 to 100 times per minute, right? And that is your normal heart rate is between 60 to 100. If the heart rate goes below 60, that is called as bradycardia. If it goes more than 100, that is called as tachycardia, right? So this rhythm where action potential is only generated by the SA node, nobody else, right? It is called as sinus rhythm. This is called as sinus rhythm. So what happens? Action potential is generated at the SA node. It is propagated to the ventricles and as well as to the atrium. So atriums will contract. The blood goes into the ventricles. Now ventricles, they have the blood, they will contract and push the blood out. So left ventricle pushes the blood out through aorta to your organs and tissues. And that is why the normal heart rate is in between 60 to 100. Lesser than 60 is bradycardia, more than 100 is tachycardia. So the first thing you need to understand is the function of SA node, it is to spontaneously generate action potential without any stimulus. AV node, it is also similar to SA node. It can also generate, but normally it does not. AV node can generate if SA node is hypofunctioning, if SA node is not adequately functioning. Otherwise, the role of AV node is just to act as a gate to open and allow the action potential to pass. Whereas the role of myocardial cell, it is only to respond to the action potential that comes from SA node. The myocardial cell, they will respond, they will get depolarized and they will contract, which means what? Basically, from physiology, what you need to understand that there are two types of cells in heart. Two types of cells in heart. One, the cells of SA node, AV node. Second, myocardial cells. And what is the difference? SA node, AV node cells can spontaneously depolarize without any stimulus, but myocardial cells will get depolarized only if they get the action potential. So the role of myocardial cell, it is only to contract, not to generate action potential. But if the reverse happens, then problem arises. So basically, what I need to know is what is the difference in the action potential generation. What is the difference in the action potential generation in these two type of cells? So yes, so this is a basic physiology. There is something called as RMP or resting membrane potential, which is different in your myocardial cells and in the cells of SA and AV node. So what is the basic difference, guys? The resting membrane potential in a myocardial cell, it is about minus 90 millivolts. whereas in a cell of SA node, AV node, it is minus 60 millivolts, which means what? It is relatively easier to depolarize a cell of SA node, AV node, and that is why they can spontaneously generate action potential. Now, what happens in a myocardial cell? How does it get depolarized? See, depolarization is because of sodium channel opening. So sodium channels open, the graph moves up. Then there is a slight dip, and this slight dip is because of potassium channel opening. And once potassium channels opens, it is counteracted by the calcium channels. Calcium channels open, and the calcium channel opening, it maintains the plateau phase. And a time comes when the calcium channels begin to close and more potassium channels open. And this is what is called as repolarization because of potassium channel opening, right? So this is the basic physiology. You know about this. So I'm not spending a lot of time here. So what happens? Depolarization is because of sodium opening. Graph moves up because positive ion is gained by the cell. Negativity decreases. Then there's a slight dip or increase in negativity because of opening of potassium channel, loss of potassium. But as soon as it opens, calcium channels open, calcium begins to move in to counteract this potassium. There is a plateau phase. A time comes when potassium channels will open because calcium channels are closing and potassium moves out. There is a repolarization. It comes back to minus 90 millivolts. Now, what you need to understand here is what is that is causing depolarization in a myocardial cell? It is sodium channels. But in case of a cell of SA node, AV node, you can see here the RMP is minus 60 millivolt. Minus 60 millivolt, here it is minus 90. So here depolarization in a cell of SA node, AV node will happen from the level of minus 60 millivolts. Here also there is depolarization, there is repolarization, there is hyperpolarization. Now here there is hyperpolarization, and then there is another depolarization in case of myocardial cell. But the difference is, as compared to myocardial cell, there is an immediate depolarization that happens. There is an immediate depolarization that happens in cells of SA node, AV node, which does not happen in your ventricles. The reason being, ventricles, they are pump, they're contractile organs, right? Tissues. They need to contract, then relax, collect the blood in diastole, then contract and pump the blood out. So they need time to relax. But in case of cells of SA node, they don't have time. They have to throw the beads one after another, so that your heart keeps on contracting. Now, guys, there must be something different here. There must be something different here which triggers an immediate depolarization in the SA node cells. And there's something different here is called as funny current. And funny current is generated by a sodium potassium channel. Sodium potassium channel. So what this funny current does, this funny current, it triggers depolarization, but it does not cause depolarization. What causes depolarization is here because of opening of calcium channels. So here depolarization is not caused by sodium channels, it is caused by calcium channels. Everything else is similar. So the point of difference that I need to carry myself forward to understand. So this is what I need from physiology, right? I'm trying to make you understand why physiology is important, to understand pharma, why pathology is important. I'll talk in a short while to understand pharma. So in physiology, I must learn this, that sodium depolarizes myocardial cell, but calcium depolarizes cells of SA node and AV node. If I don't know this, I'll never be able to understand treatment of arrhythmia. Why? Try to understand now. That is what I'm going to discuss next. If I know these basics, then you can understand that to treat arrhythmia, what can I do possibly? For example, see guys, let me talk about arrhythmia. Let me talk about arrhythmia. It is an abnormal rhythm. So what could be the abnormal rhythm? Let us see. See, suppose this is my heart and this is my SA node, AV node. This is my conduction system and this is my myocardial cell. I'll apply the knowledge of physiology to understand treatment of arrhythmia here. Now guys, all of you understand that what I've learned from now, that action potential generation in cells of SA node, AV node is because of calcium, whereas action potential generation in cells of myocardium and the conduction system is because of which ion, guys? Is because of sodium. That is the basics from physiology. Now see how I will build up pharma from this physiology point. Let us talk about arrhythmia that arises from the atrium. Now guys, arrhythmia that arises from the atrium is, what do you call an arrhythmia that arises from the atrium? Guys, what is SVT? Supraventricular tachycardia. And what is supraventricular tachycardia? That arises above the ventricle is called as supraventricular. So where does it arise? To be specific, in the atrium. Now, supraventricular tachycardia, whenever I talk about supraventricular tachycardia, I need to understand what is my aim. What is my aim of treating supraventricular tachycardia? Try to understand, guys. There are two types of arrhythmia. If it is arising in the atrium, it is supraventricular tachycardia. If it is arising in the ventricle itself, it is ventricular tachycardia, right? And the second type is ventricular fibrillation. So the name itself tells you ventricular tachycardia, ventricular fibrillation. Mostly they arise from the ventricles. They can also come from atrium, right? But the atrial tachycardia, they always arise from the atrium. Now try to understand the basic difference. See, this is a normal at normal heart rate. This is arterial contraction. This is ventricular contraction. Atrium contracts, blood goes into the ventricle. Ventricle contracts, pushes the blood out, right? So this is normal contraction. Now, in case of supraventricular tachycardia, you can see this was normal contraction. And now supraventricular tachycardia, heart is not able to adequately contract. I mean, atrium is not able to adequately contract, but there is no problem. Ventricular filling is not much affected because gravity will pull the blood into the ventricles. So patient will not die because of supraventricular tachycardia. The only problem with supraventricular tachycardia is because of some stasis of blood in the atrium, there can be thrombosis and cause stroke. But the problem arises when this arrhythmia from supraventricular tachycardia comes into the ventricle and causes ventricular tachycardia or fibrillation. This was the normal contraction of ventricle. Now, what happens if this tachyarrhythmia or supraventricular tachycardia comes into the ventricle from the normal contraction? Now the contraction decreases. It is not able to adequately contract, and this is your fibrillation, where it is not contracting completely. So the patient will die because ventricular tachycardia can lead to fibrillation, and finally there can be asystole or cardiac arrest can be seen, which means what? Whenever I'm dealing with supraventricular tachycardia, what is my aim? My aim is to prevent this supraventricular tachycardia from becoming what? Ventricular tachycardia or fibrillation. And because of that, I will block the conduction of action potential from atrium to ventricle. And for that, I'll close the gate to the ventricles. What is the gate of the ventricles? What is the gate from the atrium to the ventricles? Action potential from SA node, it comes down, then it passes through what? To the ventricles. Through what? Through the AV node, which means what? Through the AV node. Very good, AV node. That means what? In case of SVT, what is my aim? It is to block which node? AV node. It is to block which node? AV node. So whatever be the type of supraventricular tachycardia, what are the types of supraventricular tachycardia? Supraventricular tachycardia can be PSVT, paroxysmal supraventricular tachycardia, arterial fibrillation, and arterial flutter. So whenever I talk about these types of SVTs, my main aim, it is to block the AV node. Now you tell yourself, to block AV node, should I be blocking calcium channels or should I be blocking sodium channels? What do you think? If I want to block AV node, it's quite obvious. I need to block what? Calcium channels. I need to block calcium channels. Apart from calcium channel blockers, very good guys, calcium channels is the right answer. Apart from calcium channel blockers, what else I can do here is to block AV node. If I want to block AV node, calcium channel blockers is one important class of drug. Other drugs that I can use, these are called as A, B, C, D. And the C is calcium channel blocker. The preferred one is verapamil. Whereas A stands for adenosine, B is beta blocker, because beta blocker, the beta receptors, beta 1, they increase conduction in AV node. So by that I can block beta receptors and block AV conduction. And third, the fourth one is digoxin. What digoxin does, what digoxin does is digoxin is a drug which has parasympathomimetic effect. So parasympathomimetic effect blocks AV node and blocks AV nodal conduction. So I have only four classes of AV nodal blocking agents: A, B, C, D. Adenosine, beta blocker, calcium channel blocker, verapamil, and digoxin. Why calcium channel blocker? All of you know, right? So by blocking sodium or potassium, I'll not be able to block AV node. So to block AV node, these are the four classes of drugs used. Whereas, so let me see where I can use these drugs. Guys, adenosine by intravenous route, it is the drug of choice for an acute attack of PSVD. It is drug of choice for an acute attack of PSVD. It is a drug of choice for an acute attack of PSVD, paroxysmal supraventricular tachycardia. But remember, whenever a patient comes to you, the first thing you do is not PSVD. You do is called as Valsalva or carotid massage. Because Valsalva or carotid massage, what it does, it has parasympathomimetic effect and blocks AV node. So what we do is, see, for example, in this case, a patient comes to us in the emergency with acute attack of PSVT. I'll insert a cannula and prepare for IV adenosine by rapid IV push. I'll give this drug. But by the time I'm preparing the patient, I can go for carotid sinus massage and Valsalva, any one of these two, and it will help us in some cases to abort the attack. So remember how the MCQs can be asked in the next exam or your screening exams is, what is the first thing to be done? And then your answer would not be adenosine. The first thing to be done is a Valsalva or carotid massage. But if they ask you which is the drug of choice, then obviously your answer would be adenosine. And if they ask, suppose if I cannot give adenosine, see guys, if adenosine cannot be given, then my order of preference is 1, 2, 3, right? Why adenosine cannot be given? For example, adenosine is a bronchoconstriction. I mean, it is a bronchoconstrictor. So if there is a case of supraventricular tachycardia or paroxysmal supraventricular tachycardia with bronchial asthma or COPD, if this is attached, in this case, what would be my drug of choice? You understand? Even beta blockers cause bronchoconstriction. It is also gone. What comes my second line? That is, here my drug of choice would be intravenous verapamil. So a lot of times your MCQs would not be direct. They'll give you acute attack of PSVD and bronchial asthma COPD. What is my drug of choice? Your answer would be IV verapamil, right? So these are the drugs which block AV node, and by blocking AV node, I can use these drugs for treatment of different types of arrhythmia. So blocker, AV nodal blocker, I have only four classes, A, B, C, D. But now guys, if you, very good guys, very good. If you look at, now similarly, I'm just trying to give you a hint into how to correlate. So this is how we correlated physiology into pharmacology, and we learned that calcium channel blocks AV node. Now, we'll try to learn the second part. If my arrhythmia is in the ventricle, that it is ventricular tachycardia or ventricular fibrillation, which means my arrhythmia is in the cardiac tissue, in the ventricular tissue. Now, will AV nodal block produce any effect? What do you guys think? Will I use AV nodal blockers here for these arrhythmia? Will I use AV nodal blockers? Yes or no? What do you think? Will AV nodal blockers be a good choice for treatment of ventricular arrhythmia? Obviously, no, because they have already passed the gate. They're inside your territory. So I cannot use, these are not used. They are not used. So what am I going to do for ventricular tachycardia and fibrillation? I am going to target what? I am going to target your myocardial cell. And you see, in myocardial cell, if you remember, we talked about that in a myocardial cell, cells are depolarized by which ions? Sodium channels. So I'm targeting myocardial tissue in the ventricles. For that, I will prevent a myocardial cell from getting depolarized. How can I do that? Number one, I can block sodium channels, which means whenever I'm treating an arrhythmia, that is ventricular tachycardia or ventricular fibrillation, I can go for sodium channel blocker. right? Can you tell me what else can I do so that the myocardial cell cannot be depolarized? One is pretty obvious, that is sodium channel block. What else can I do? What else can I block? What do you think, guys? I'm blocking sodium channels. Excellent, all of you. Come on, guys, let the answers flow. What else can I do? All right, think. This is a basic physiology. A cell gets depolarized. A cell gets depolarized, and after that, it gets repolarized. Then again, it gets depolarized. But a cell will get depolarized only if it gets repolarized. So if there is no repolarization, if there is no repolarization, there is no depolarization. Means which channel can I block, guys? I can also block potassium channels. So if you block potassium channel, there is no repolarization and there is no depolarization, which means there are two ways by which I can target physiology and block depolarization of a myocardial cell, block sodium channel and potassium channel, which means what? You can see here, that is for treatment of ventricular tachycardia fibrillation, for these arrhythmia, I can block sodium channels, I can block potassium channels. So basically what we have divided our antiarrhythmic drugs into two groups. One group of drugs are called as AV nodal blocking agents, and the second group of drugs, these are drugs which target the myocardial tissue. So these are blockers of myocardial tissue, and these blockers of myocardial tissues, they are either potassium channel blocker or sodium channel blocker, right? And these drugs, when I block myocardial tissue, these would be primarily used in ventricular tachycardia or ventricular fibrillation. Which is the drug of choice? Guys, remember, for VT or VFib, the drug of choice is potassium channel blocker, that is myodaron. It is the overall drug of choice. Excellent. Amiodaron is overall drug of choice, but there is one exception. There is one exception, and that exception where myodaron is not the drug of choice. Can you tell me what is the exception? The exception is ischemia, that is ischemia-induced ventricular tachycardia or fibrillation. So which ischemia can induce VT or VFib? I mean, which disease? These are myocardial infarction or angina. So, there is a decreased oxygen supply that causes ischemia. And if that causes ventricular tachycardia or fibrillation, amiodaron is not my drug of choice. Now, here comes pathology. Why in VT or VFib caused by this MI or angina, I'm not using this drug? The reason being, see, what happens here is any cell, guys, any cell in your body, when it is under the effect of ischemia, suppose this is my myocardial cell under the effect of ischemia, it increases the cellular permeability for an ion called as calcium. And this is the reason why whenever there is some kind of shock causes hypocalcemia. Yesterday a student asked me, sir, why shock causes hypocalcemia? Because shock causes hypoxia, and hypoxia increases permeability of the cell membranes for calcium ions. Similarly, ischemia or this MI or angina, they increase permeability for calcium. Now try to understand, when there is too much of calcium, then what happens? This myocardial cell in your ventricle, it kinds of thinks as if I am also SA node, because SA node is depolarized by which ion? Calcium. Now myocardial cell thinks I am also like the almighty SA node, and I can generate action potential on my own. So that area of MI or angina causing ischemia begins to generate action potential just like SA node, and this action potential is what is causing ventricular tachycardia and fibrillation. That is why patients of MI, they die immediately due to ventricular fibrillation because of this action potential. But now you need to remember, the most important part is I have sodium channels here. I have these sodium channels, and usually a myocardial cell is depolarized by which ions? Sodium. But tell me, if calcium is depolarizing this myocardial cell, will sodium channels be in closed state or open state? So the area of MI, wherever I have the cardiac tissue, the myocardial cells, the sodium channels, will they be in closed state or open state? What do you think? Closed state, very good. They would be in closed state, not open state, because the cell is persistently depolarized. And remember, the best drug, because other sodium channel blockers, no drugs, they act upon a sodium channel in closed state. The only drug that acts upon the sodium channel in closed state is lidocaine. It's a very commonly asked MCQ, even in MCI screening in NEET PG. They commonly ask, what is the drug of choice for ischemia, induced ventricular tachycardia, or ventricular fibrillation, or MI or angina induced? So this is your application of pathology. In pathology, we study that what ischemia does to a cell. Ischemia increases permeability of calcium ions into the cell. And because of that, I'm having a situation here, sodium channels are closed. So guys, here we have discussed in this arrhythmia, in this short discussion, my aim was to tell you how we basically, in this case, correlate physiology to pharmacology. Calcium channels blocks AV node. Pathology to pharmacology. Calcium channel permeability increases by ischemia, and that is why lidocaine is a drug of choice. Then we connected to medicine as to how a procedure like Valsalva should take precedence over adenosine. So I should know these nitty-gritties, and this is what I weave in pharma. So I need some time whenever I teach so that I can make you understand those things, because I'm a firm believer, guys. If I understand a thing, I'll remember them for a longer period of time. If I don't, if I mug up, sooner or later I will forget. And you would have seen the MCA exam, the questions which are being asked nowadays. It is no longer about mugging up things. It is about understanding. You have to understand things, and then only you can solve the topics. So this is not entire antiarrhythmic drugs, because that will take me 2 hours, right? So this is just an intro into how I can treat arrhythmia, and most of the MCQs you can solve from this, because I've given you a basic idea that in arrhythmia, either I have to block AV node or I have to block cardiac tissue. If I have to block AV node, I'll be using ABCD. If I have to block cardiac tissue, I have to use either sodium channel blocker or potassium channel blocker. Are you clear with this, guys? So now see, I have explained the topic. Now I'll try and solve some questions, and I need some answer from you guys. All right, so you can look at the questions, guys. I want participation from all of you, and we will see whatever we have learned here. How can we apply that, whatever we have learned, to solve MCQs, right? Question number: which of the following drug is class 1 antiarrhythmic drug? Which one is class 1 antiarrhythmic drug? So I'm telling you what are the basic MCQs they ask you. See, there are 5 classes. There are 5 classes of antiarrhythmic drug, and class 1, they are sodium channel blockers. Class 1 are sodium channel blockers, and we discussed lidocaine is a sodium channel blocker. So this is one type of MCQ. So I'm just giving you a hint as to how MCQs are asked from antiarrhythmic drugs. This is a very basic MCQ, and it is asked in MCI screening as well. So they'll ask you which is class 1, 2, 3, 4, 5, right? Second, in a patient of acute attack of PSVD, which of the following is done first? IV adenosine, IV verapamil, Valsalva, hyperventilation. Now, if you look at such kind of MCQs, there is a trick. They'll give you the first option, which is a honey trap. 50% of students will jump into adenosine. They will not even look at option B, C, or D. Make it a point that whenever you solve such questions, go through all the options. So Valsalva, as I've already said, guys, it is a better answer is Valsalva. Ischemia-induced ventricular arrhythmia is best treated by. It's a very commonly asked MCQ, because MI is so common in India nowadays. MI is very common in India, right? So what is the answer? We have discussed, guys. Answer is lidocaine. Excellent, guys. I'm proud of all of you. Excellent. Lidocaine. You guys are a great bunch of students nowadays, and that's really great. Ischemia-induced ventricular arrhythmia is best treated by lidocaine. I've told you the reason why. Now, this is something which we need to little bit solve here. A patient of atrial fibrillation with arterial rate of 200 beats per minute and a ventricular rate of 150 beats per minute was administered a drug, after which arterial rate did not change, but ventricular rate became 100 beats per minute. Which of the following drug was administered? So this is a clinical type of question, which is probably, this is the questions how they're going to ask in your next exam, right? So you just have to apply your knowledge that I've given you. See what it is saying. See, you need to picture the question in your mind. The arterial rate is 200 beats per minute. Ventricular rate is 100 beats per minute. This is normal. Now, ventricular rate is 150 beats per minute. Now what happens? I give the drug, and after giving drug, arterial rate is same, but ventricular rate becomes 100 beats per minute. It's a very simple question, guys. Which drug is it? Arterial rate is high, ventricular rate is low. So this is application based question. You tell me. I have already told you. There are two things. So you need to learn how to think. There are two things you can target for arrhythmia, either AV node or myocardial tissue. What are you targeting here? First, find that. Don't blindly look for answers. Am I targeting AV node or am I targeting myocardial tissue? What am I targeting here? If you find that, your answer is in front of you. What am I targeting? AV node or myocardial tissue? What am I targeting, guys? AV node, which means what? This question overall is asking which of the following is an AV nodal blocker. Overall, this question, isn't it? This question is all about which of the following is an AV nodal blocking agent. And which one is it? It is verapamil. So I told you how to think. Don't blindly go for the options. Look at the question, analyze what is it asking you, find the target, then find the answer. So whenever you look about antiarrhythmic drugs, think what is my target? Cardiac tissue or AV node? Your 50% of job is done. Next question, guys. Which of the following class of drug can cause QT prolongation as a side effect? QT prolongation. Which of the following class of drug can cause QT prolongation? Class 2, class 3, class 4, class 5. Tell me, which class can cause QT prolongation? Class 2, class 3, class 4, class 5. So remember, this is the normal graph, and the distance between depolarization and repolarization, it coincides with the QT interval. So whenever I block potassium channels, there is a delay in repolarization, and that causes QT prolongation. So what lies behind the concept of QT prolongation is block of only one channel potassium, which can be blocked by two classes, class 1A and class 3. All of you have given the right answer, guys. Class 1A, class 3. So answer is B, that is class 3. Class 3 is the right answer. Number 7, transient asystole as a side effect can be seen with which drug? Transient asystole as a side effect can be seen with which drug? Transient asystole. Now again, try to think in terms of blocking what will cause asystole, myocardial tissue or AV node. Myocardial tissue or AV node. Blocking what will cause asystole? Myocardial tissue or AV node. What do you think, guys? Many of you might think myocardial tissue. If I block myocardial tissue, it will decrease contraction. It will decrease the rate of contraction, but it will not cause asystole. For asystole to happen, I have to totally block the AV node. So that would be a toxicity of AV nodal blocker like adenosine beta blocker or verapamil. And if I totally block the AV node, zero impulse conduction from atrium to ventricle, from SA node. Ventricle has no current. It will not contract. In other words, here, what I'm asking, which of the following is an AV nodal blocker? Okay, the same thing, which is an AV nodal blocker. Your answer is adenosine. You got my concept, guys. The questions might be asked in different way. Questions might be asked in different way, but the concept is same. And if you remember the concept, if you understand the concept, you can always solve the answers. AV nodal block can be achieved by blocking which channel? Sodium channel, calcium channel, potassium channel, chloride channel. It's an easy one. This is how the MCA screening questions are asked nowadays. Sodium channel, calcium channel, potassium, chloride channel. So what is the answer? So it's easy one, guys. The answer is calcium channels, right? So I've given some difficult questions, some easier ones. Which of the following drug is class 1 antiarrhythmic drug? All right. So this is something we have already done. I'm sorry. So this is a repetition. Verapamil should not be combined with beta blocker due to risk of. See again, question is different. Question is different, but the concept is same. Verapamil should not be combined with a beta blocker due to risk of what? You must still find the answer, guys. Because I've already told you, you need to find out what is being affected, myocardial tissue or AV node. Myocardial tissue or AV node. You know that I told you ABCD, B for beta blocker, C for calcium channel blocker, both can block what? AV node. And so the reason why I should not combine verapamil with beta blocker is both can cause what? Both can cause what? Conduction block. So you got my point. We have already solved 3 MCQs, which is being solved on the same concept. Am I targeting AV node or am I targeting the myocardial tissue? AV nodal block is effective in all types of arrhythmia except. AV nodal block is effective in all types of arrhythmia except. Now again, this is again the same concept is going to help you solve this MCQ as well. PSVT, atrial fibrillation, atrial flutter, ventricular fibrillation. See how easy this MCQ is. If I block AV node, I'll be using it in all the 3 ABC, but ventricular fibrillation, AV node has no role. So guys, this was my aim here. To give you guys an introduction into how see nowadays, you know, right, your MCA screening, MCQs are not repeated, right? MCQs are not repeated, topics are repeated. So the same topic of antiarrhythmic questions will be repeated, but if you just mug up the user side effects, go to the exam, you might not be able to solve the new questions. For that, you need to understand. And in arrhythmia, what I need to understand, which are AV nodal block, which are cardiac tissue block. What happens if I block AV node? What happens if I block cardiac tissue? As simple as that. See, first time understanding might be difficult, but once you understand it, it remains with you forever, for the eternity of your life, right? Now, guys, so this is what I had planned today. Apart from that, as I had promised, I'll talk a little bit about the next exam. What is the next exam? And let us talk about the next exam a little bit, guys. All right. Now, see, what is next all about? Let us try to understand. What is next all about? See, guys, it does not matter. So next is about integrating the IMGs with the FMGs, isn't it? So the IMGs and FMGs does not matter where you get your degree from, an Indian medical college or a foreign medical college. At the end, you get an MBBS degree. And once you get the MBBS degree, you'll have to appear for the next one exam, which is MCQ based. And usually here, they'll give you 50% as the qualifying criteria. And if you are qualified, yes, then you can go for internship. Unfortunately, if you're not qualified, you'll have to reappear for the next exam. And this is a loop, right? Until and unless you clear it. You qualify, you go to the internship. After that, you'll be able to appear for the next 2 or the clinical exam. And it would be something like the OSCE exam, which happens in the Western countries, where it is, you'll have dummies or the patients or the pseudo patients, right? Where you have to show your clinical skills, right? Examination of patients or a disease, identifying symptoms or signs. And once you qualify it, yes, you qualified, you get a license to practice. So you become basically a registered MBBS doctor. If you're not qualified, you reappear for next two. Now, how many attempts you might get, I think it has not been specified. Guys, this, what I'm telling you, is what has been proposed. It might undergo some changes, God only knows, because this has taken a backseat because of COVID. But hopefully, with COVID, Omicron, little bit relaxing, right? It's not that much virulent. So things might change. But I feel that they might give you three attempts for next two. If you don't clear in 3 attempts for next two, you might have to give or re-attempt next one exam. Now that is usually what they do in the DNB exams for broad specialty and other exams, right? DNB PG. So they might do that, and you get the hell out of this loop of next one, next two practice. Then what happens is, based upon your next one, once you get the license to practice, your internship is done, you'll go, and based upon the rank you have scored, you'll get a PG seat as well. So you get the license to practice, your internship is done, then directly you join PG, you complete your PG, and then you do whatever you want to do in your life. So this is what is the proposed next exam all about, guys. And this is pretty much what I intended to discuss today. Right. So tell you what I had to tell, that never lose heart because you're an FMG, or you're looked down upon or anything like that. Things might happen sometimes, but you see what happens is, people might look down upon you for some time, but after some time they will accept you and you'll move forward. So don't pay attention to anyone saying anything. Just you focus on what's your job, do your job properly, and nobody can do anything to you, right? Just you can move ahead. So guys, that is what I had to offer today to you guys. Now if you have any questions to me specifically, anything, guys, shoot. You can shoot the questions at me and I'll try to answer them as much as I can, guys. So I'll try to always help you guys. I always have a soft corner for the FMG students, because you know the reason. And whenever you have any doubt, guys, any doubt with respect to pharma, with respect to exam, or with respect to life, what to do in life, which subject to choose, you can always message me. And because Instagram is where I reply all my queries. So in Instagram, you can, is my Insta handle, doc Pharmaniac. So you can basically message me anything you want, guys, any doubts you have, anything. All right, so let me have a look at your questions, guys. So
do you want me to read out? There are few questions.
yeah,
There are few
okay.
questions people are asking about how to prepare for MAC for December FMG exam. Some for June FMG exams and for December FMG exam.
See, guys. Okay, so let me see. So okay, you tell me the questions, and I'll answer the queries, right? So they're asking that how to prepare. Okay, so you're asking me how to prepare for the MCI screening exam December and June, right?
Yes.
So MCI screening exam December or June. Now, does not matter which exam you are targeting. Now, to begin with, for December guys who are targeting December, guys, I'll tell you first, and then whatever I tell you for the June exams, it also is the same for you guys when you go for the last 5 to 6 months of that. Now, for December, you have ample time now. So, guys, you should try to finish, right, to cover the subjects which you have, cover the subjects, and at least when December is the exam, so by September minimum. See, if you can cover up earlier, it is good, but don't try to rush it. If you need 1 month more, if you need October, then it is fine. Then you can plan for your revision, because you have more time. You can easily go and finish all the subjects, plan your revision, right? And try to, so see what happens is, if you go blindly, you'll never be able to cover. So whenever you prepare for something, Make timetable. Make timetable, count the number of days, divide the number of days into different subjects, then divide the days into number of hours into subtopics, and then you have target for every hour, that in this 1 hour I have to cover GIT, in this 1 hour I have to cover recipe in pharma, for example, because they're smaller topics. This 6 hours is where I'll cover CVS. So you should have the target every hour. Otherwise, you'll not be able to achieve what you need to study in one day, and then not be able to achieve what you need to study in 1 month. Right, my point? So that breaks down to every hour. Now, students who are going to appear for June exam, remember, the last 1.5 months, 1.5 months means 45 days. Now, if you ask me how many days you should have for revision, it should be around 30 to 45 days. I mean, if you don't have 45 days, it does not mean your preparation is jeopardized, right? So at least 30 days, guys, at least 30 days, and minimum 45 days. You need to revise. You need to revise what you have studied earlier. But remember, in this period, you don't need to do anything new. Nothing new, nothing. Remember, if you have left some subject, like for example, I have left radiology. For example, I'm saying I was doing my subjects, and I left radiology, and now I have 30 days for the exam. Now I'm thinking, should I give 3 days for radio and then do something else? What should I do? I should not give 3 to 4 days for radio. I should not take away my days of revision. What I'll do is, in this radiology, I'll solve only MCQs, and every day I'll take 1 hour, and for 5 to 6 days I'll solve some MCQs of radiology and be done with it. So guys, remember, nothing new, because remember, 19 subjects are there. But even if you're good at 15 subjects, you can still cross 150. You're good at 15 subjects, 3 to 4 subjects you're not very good at. Try to manage by solving questions, MCQs, or following the revision videos, or doing something else, right? So you did not be master of all 19 subjects in MCI screening. That is one thing you have. That luxury you don't have in PG exam, because you have to be at your level best in each and every subject, because nobody is giving you a seat. You have to snatch a seat from someone else. But in case of MCI screening, you have your own way. Everyone can get 50%, right? You're not snatching a seat from anyone. So that is the most important part. Second part is, whenever you prepare for an exam like this, or a competitive exam like NEET PG, you need to understand that whatever I do every day, whatever I'm studying every day, I need to keep one thing in my mind, and that is, every day, whatever I do, I need to keep one thing in my mind, is how am I gonna revise this content later? Because if I cannot revise it, it is as good as not studying it. So revision is very important. And if I come across a topic which is very vast, and now I'm having difficulty even in the first reading, I'm not able to wrap my head around it and make the heads and tails of that topic. So what will happen in revision? If I go to revision and open the topic, I'll be doomed. So I need to take that challenge head on. And today, when I'm studying it, I need to reinvent myself, do something new. For example, suppose today I studied for 10 hours, which is quite impossible, let us say 5 hours, bacteriology, and I studied bacteriology for 5 hours. And what I'm trying to do now is, I cannot make heads and tails out of this bacteriology, and I know in the back of my mind, everybody knows I'll not be able to revise it. So what should I do? What should I do is, I should take a big chart paper and write down bacteriology, write down cocci, rods, miscellaneous. Cocci I should classify as gram positive, gram negative, similarly gram positive, gram negative, and write down the selective important MCQ points only in this chart paper, paste it on the wall. And And I know that bacteriology is a very difficult topic. I did the same thing when I was preparing for MSI screening. There were four, so I did not have a chart paper, but I had four A4 size paper where I had drawn them systematically and I'd post them. And for 1 week, I'll continuously just sit for 15 minutes, 20 minutes and look at that chart. So at the end of the day, what has happened is even today, when did I give the exam? I gave the exam in 2007, right? So it has been a good, how many years? 13, 15, 16 years. I still remember that flow chart where I was written, there was cocci, then there was staphylococcus, it was coagulus positive, streptococcus coagulus negative, right? Pinhead appearance, golden colony appearance. I still remember it. Can you see that? So the effect that has, this is called as pictorial memory. You guys must have watched a movie called as Drishyam, and the best dialogue of Drishyam was, whatever you see, you don't forget. जो आप देखते हो वो कभी भूलते नहीं, right? That is the impact it has on you. So you have to do this. For example, I have a particular syndrome, like for example Cushing syndrome, and I'm not able to remember what happens in the Cushing syndrome. So I'll draw a diagram, a moon faces, right? Buffalo hump, abdominal obesity, right? And then I'll make some strides. Then I will make hairs are falling, right? I'll make an eye, one eye big, so glaucoma, cataract, right? And I'll make a stomach, there is ulcer. So what I'll do is I will convert all the words in that syndrome or disease into a damn diagram, so that I can at least remember that diagram. So this is how you need to reinvent yourself, right? So what I mean to say is, every day when you are studying for the exam, try to analyze, how the hell am I going to revise this in the last month? And if you think you can easily revise from the notes, it's okay. But if you think you're going to have difficulty, try to redo it. It will take half an hour or 20 minutes. You can do that, right? So every day you're going to do that. Second, try to prepare for the last month of revision. Now, guys, whenever you have your notes, when you go through the phase of revision, you don't have to revise all the points. Try to understand this. You have to revise only those points which you have marked as Q. So in the last month, you'll only revise those points. Third, 20th notebook that a lot of faculties talk about. 20th notebook, it is essential. Either you can make a 20th notebook, or what I used to do is, in the note of every copy, I used to take 5 to 6 pages, and in those 5 to 6 pages I would write down something. For example, in micro, what I used to do, I'll write down the names of the media which are used, the appearance, types of appearance, like the pool of fish appearance or Chinese letter pattern appearance in diphtheria, right? Peanut appearance, or the golden color appearance, or the media which are used, Ludlam's media, this and that, the temperature, oven temperature. So I'll write down all these important stuffs which I tend to forget, which are important, which are high yield, in the last 4 to 5 pages of my micro copy. The same thing what I used to do with pharma is, I used to write down the drugs of choice, all the drugs of choice, at least, so that I know the drugs of choice. In biochemistry, what I used to do is, I used to write down the rate limiting enzymes, right? And the important stuffs like how many ATP are produced, or the important cycle, important part of the cycle. So basically what I used to do is, whenever I'll revise in the last 45 days, I'll do one revision. I'll do one revision for around 35 days, big revision, and one small revision for 10 days. And you know that it is not possible. So I can have 10 days, I can have 7 days, whatever it is, whatever I can afford, I can go for that. Now, whatever number of days I have, 7 days or 10 days, you know that it is not possible to revise the entire content. What I did on the last 7 days, is revised only those 4 to 5 pages for each subject which I had, right? And by doing that, what happened is, the high yield content in each subject I could revise, in the last 7 to 10 days. So guys, by doing all of this, what it does is, it increases your probability. It increases your probability of getting, crossing the 150 mark, and What you need to understand is, second thing is, when you go to this exam, you know that there is no negative marking. That the part I'm going to tell you is very important. Remember this. There is no negative marking. That means what? See, out of 300 questions, no matter how good you are, there would be 30 to 40 questions where, with regarding which you will have no idea, are they from this planet or they are from Mars. You have no idea about the question option. Now, what you should do about this? Most MCA students, they don't know about it. I don't know. I mean, why they don't know? This is a basic mathematics, right? Probability. I don't know anything about these questions, and if I go on using my knowledge or whatever I have, and going for random options, there is a probability that I get 0 marks. But if I go only for one option, either A or B or C or D, choose any one you like, does not matter. You should go for that. Now, I did the same, guys. I did the same for 30, 40 questions. I don't know which option I marked, frankly. I think it was option C, I think. I don't know. It was option C, I think. So I marked the same option. And see, the time when I gave the FMG exam, marks were not declared. We are not given the marks, right? But after, I think 4 to 5 years or 2 to 3 years, they started declaring the marks. I went and to the NB just because I had also this, by how much marks have I passed. So my marks were 155, right? It was my first attempt. I studied for only 2 months. I studied only 14 to 15 subjects. Rest I did some MCQs as much as possible, but I could gather 155. Now I know in my head, if I had not gone for 30 to 40 questions, same option, I would have stuck in between 147, 148, something like that, right? So you see, it is all about, not only about hard work and IQ, it is also about smartness. You have to show your smartness in getting through the finish line of 150 marks. If you're a good student, you can easily score tops, 100, 90, 200, etc. And see, you guys have the luxury. You are being taught in English. You know in which language I have studied? I have studied in Russian. The anatomy, physiology, biochemistry, patho, medicine, everything was in Russian language. So I didn't. By the time I came to fifth year in Simferopol in Crimea, I did not know even what is hemoptysis in English. Hemoptysis in Russian is called as krava karkanie. Krov is blood, karkanie is to spit out. So now spitting out blood is called as hemoptysis. So that is when I had to work hard and transform myself from Russian to English. But anyways, guys, with adequate hard work, smartness, and you can always cross it. So if in later stages if you have any doubts, you can always send me an Instagram, and I'll be more than happy to answer. Any more questions?
So there were two frequently asked questions. Will the syllabus be sufficient if we are preparing for next and USMLE? Will the
syllabus is same. Syllabus is same. In fact, the Indian syllabus is more than it is required for USMLE, right? So you can do the same syllabus. Theory of Marrow is more than enough for USMLE. Plus, if you're going for USMLE, then solve some questions, USMLE questions of USMLE. Practice is important because their style of asking is little bit different. But since Marrow is more clinical, it is more in-depth, it is more apt for USMLE, because USMLE, the questions, they won't test how much you remember. They will test how much you know, learning. That one I told you, AV nodal block or cardiac tissue block, right? So they will ask you questions in that sense. So yes, it is, the content in Marrow is more than enough for USMLE. You just have to practice USMLE style questions, right? Anything else?
I mean, then it is same for PLAB also, right?
See, PLAB also it is same, but again, you have to solve questions of PLAB by some source like Plabable or some other source. See, the content is same. Content does not differ much. The only thing differs is how the questions are asked. The PLAB question asking is different. They've extended matching questions and match the following and this and that. So you have to practice those questions. Otherwise, theory is, you go anywhere in the world, guys, it is the same antiarrhythmics. These are the same digoxin, same valproate, same lamotrigine in antiepileptics. There is no difference.
Okay. So second question is, for example, I have done my internship in the respective country where I am studying. So should I do an internship after my next one?
I didn't get your one. What did you ask?
I have completed my internship in the respective, respective country or the respective uh, wherever I'm studying. I have done my internship.
They have to do internship in India as well.
Okay, after next one.
Yeah, they have to do internship here as well.
Okay. So the last question, are the revision videos sufficient for FMG, clearing FMG?
So revision videos are sufficient. They're sufficient for clearing FMG exam, provided you should practice MCQs. Now, guys, remember, this is a very huge mistake that students do. That if I'll only study the theory part, I'm a master of theory, I'll be able to crack the MCA screening. No, guys. Every day for 1 to 2 hours minimum, you should solve questions. Time is less, but because this is a question MCQ based exam, if you don't practice MCQ, you'll not be able to cross this exam. Not solving MCQ is one of the reasons why many students fail. Remember, having knowledge of a topic is one thing, but solving an MCQ is another kind of art, which you need to hone every day, solving questions. You read a topic each day, make it a point, you solve at least 20 to 30 questions from that topic. So if you're doing topic of arrhythmia, make sure 20 to 30 questions minimum you should solve and see how questions are asked, right? So you have to do that.
Okay, thank you, sir. I think rest questions I can take off.
Correct? Okay.
Thank you.
Guys, so don't worry, guys. All of you are gonna rock, and just believe in yourself, and you will cruise through this exam. And see, remember, as I've told you, it has to be hard work, little bit of intelligence, little bit of smartness. So thank you all of you. Spasiba balshoy. Same. Das vidania. Spokojnej noci, ребята. Goodbye. Take care.
Thank you. Thank you so much, sir. Yeah. Sir, you can go. Hi guys. Yeah. Coming to, most of you guys have asked about important topics for FMG, right? So yeah. Next, we are coming up with one more session with Dr. Ranjan sir on February 18th. In that session, we'll discuss important topics. What are the high yield topics for FMGE from pharmacology, and he'll explain in more detail about how to prepare FMGE for, how to prepare pharmacology for FMGE in the next session, right? So stay tuned for February 18th. If possible, try to bring up all your friends, whoever have missed this session. Thank you. Sir, Maro important points PDF for FMG from main videos, or just do a revision modules from neat page. Yeah, we are in that plan. Yes. As a part of it, we'll start with these webinar sessions. Most of you. I've cleared my FMG on June. Then for PG, I have to follow next to clinical exam. That I'm not pretty sure. Video available on YouTube. Yes. Ranjan sir will share it on his YouTube channel. Thank you. Can we get revision PDF? I don't think so. Thank you. Thank you, guys. Thank you so much.